My name is Dr. Ganga, your nephrology educator at Prep Ladder. Today, let us discuss about IgA nephropathy. So, we are going to study this under the following headings. First, we are going to learn what is the definition of the disease, what is the etiology and pathogenesis. Then we are going to learn in detail about the IgA immune system, IgA glycosylation or the galactosylation, the clinical features of this condition, pathology of the disease, differential diagnosis, treatment and its outline, HSP vasculitis. Then we are going to look into KDIGO guidelines. And finally, we come to the quick revision section, which is a time capsule or a revision capsule, which helps in quickly revising all the important questions that have been asked in the previous exams. Now coming to the definition. IgA nephropathy is also called as mesangial-proliferative glomerulonephritis. Okay, so this is different from membranoproliferative glomerulonephritis, which is MPGN. So we have dealt a whole separate chapter about that. This is mesangial proliferation. So in MPGN, that is membranoproliferation, you're going to see endocapillary hypercellularity, you're going to see lobulations, but here there is only proliferation of mesangium. Okay, so there is mesangial proliferation. Why this proliferation happens? Because there will be immune deposits in the mesangium. Okay. Now the other name for IgA nephropathy is called as Buerger's disease, because Dr. Buerger is the one who identified the staining. Once the immunofluorescence came into kidney biopsy, IgA was identified by him first in the kidney tissue, and he told that this is leading to glomerular disease. Okay, so it's also called as Buerger's disease. So this is being asked as a question, as in once directly it's been asked that Buerger's disease is what, so that is IgA nephropathy. Other thing is, while giving the question, they might give it as Buerger's disease rather than IgA nephropathy. So it's important for you to remember this name. Okay. And this is the most prevalent glomerular disease. That is the most prevalent glomerulonephritis causing CKD ESRD, and the most prevalent glomerular disease is IgA nephropathy. So in our clinical practice, out of 100 patients of glomerular disease, 50 to 60% of patients what we are seeing are IgA nephropathy. Okay. Now let us learn about the IgA immune system. IgA is the most abundant immunoglobulin, and it is mostly plays a role in mucosal defense, like it might be gut mucosa or respiratory tract mucosa. So this immunoglobulin is majorly found there, warding off whatever infection it comes in contact with. So it has two subclasses, IgA1 and IgA2. Once the mucosa, for example, imagine it is gut tissue, it gets exposed to some bacteria or some virus, the mucosa associated lymphoid tissues which gets activated release something called as polymeric IgA. This polymeric IgA goes into the secretory glands and becomes secreted as secretory IgA, which further wards of this infection. Okay, so this is how generally it happens. However, when it is seen in the kidney biopsy, whatever mesangial IgA is this polymeric IgA. They found that this polymeric IgA is excessively deposited in the mesangium. Why now you might think that this polymeric IgA is only found in the mucosal tissue. How is it getting deposited in the kidney, right? Mesangium. So there is increased bone marrow production of this polymeric IgA, and response to mucosal immunization is impaired. So once something comes to the mucosa, only here polymeric IgA is supposed to be produced. But in patients with IgA nephropathy, it is seen that once it is exposed to any infection, this polymeric IgA is not just produced in the mucosa, but it is also produced in the bone marrow. Okay. Now, how does this happen? How does bone marrow produce this excessive IgA? It is because the mucosal IgA producing plasma cells move to the bone marrow. We know that this plasma cells is the one which produces antibodies. So the plasma cells in the mucosa which is producing this polymeric IgA, these move to the bone marrow. And that's how this is produced. Okay. Another thing is the hepatic clearance of this IgA is reduced. One is the production is faulty, as in. So one is this production is faulty. That is polymeric IgA, which is supposed to be produced in the mucosa, is getting produced in the bone marrow. Other one is its clearance is also reduced. So these both are going to lead to increased serum levels of IgA, which gets deposited in the kidney. However, high serum IgA levels is demonstrated only in 1/3 of the patients. So this is important. Okay. Not all patients of IgA nephropathy have high serum levels of IgA. Only few patients of IgA nephropathy, that is approximately 30%, that is 1/3 of patients have high serum levels of IgA. Okay. So serum IgA level are not useful in diagnosing IgA nephropathy. So you cannot use serum levels to diagnose IgA nephropathy. Okay. Now, another important step that happens in the, another important mishap that happens in this IgA nephropathy is there is deficient galactosylation. So there is hinge region of this IgA antibody, right? So in this hinge region, whatever galactosylation should happen, it is deficient. So this galactose deficient IgA1 is what is mostly seen in IgA nephropathy. Okay. And once this produced, this itself is an abnormal antibody. So what will happen? Our body's immune response will start and it will start producing IgG against this galactose deficient IgA1. So galactose deficient IgA1, right? This is an abnormal IgA1. So what will body do? It will detect an abnormal antibody, which itself is like an antigen, and it will produce IgG against this. So this complex, that is galactose deficient IgA1 plus IgG, this goes and gets deposited in the mesangium. Okay, so this is another theorem that is present. So this immune complex is what stimulates the mesangial proliferation. Now, one important thing is just presence of galactose deficient IgA1 is not sufficient. There should be some second hit. Like it could be genetic factors, it could be environmental factors, and only if there is second hit, this galactose deficient IgA1 can produce IgA nephropathy. Now, coming to the etiology and pathogenesis, whatever I explained till now, there's increased occurrence of IgA1 with poor galactosylation, that is galactose deficient IgA1 in the circulation. Then there is generation of IgG or IgA antibodies against this galactose deficient IgA1. There will be mesangial deposition of this or formation of IgG IgA1 complex or IgA IgA1 immune complex. So this galactose deficient IgA1 and the IgG or IgA. Okay. So this forms an immune complex. This goes and deposits in the mesangium. Okay. Now it has two effects. One is it goes and activates the IgA receptor, or second is it activates the complement. In here it is mannose binding lectin pathway activation or alternative pathway activation. Okay. So this gets activated and this leads to mesangial cell damage and activation of secondary pathway. Finally, this leads to IFTA. So this is the exact pathogenesis of IgA nephropathy. Now, role of infection. Role of infection is we have to know that it is synpharyngitic. Why this becomes important? Because in PSGN, that is post-streptococcal glomerulonephritis, it is post-pharyngitic. That is, after pharyngitis happens, it takes approximately 2 weeks for the nephritis to start. Whereas here, the patient will complain of sore throat, pharyngeal involvement, and simultaneously there is involvement of kidney. Simultaneously, glomerulonephritis occurs. Okay, so this could be because there is increased this polymeric IgA production which gets deposited in the kidney, or increased IgA which gets produced in the mucosa, which is galactose deficient, goes and sits in the mesangium with its antibody complex. So any of this could be the mechanism. Okay, So once mucosa gets attacked, there is non-specific activation of immune system, like just what I explained, leading to IgA nephropathy. Now, what happens once the antigen-antibody complex gets deposited? There's mesangial proliferation. There is secretion of inflammatory markers like PDGF, TGF-beta, okay? And also immunoglobulin G and complement, which is mostly C3, which gets activated to mannose binding lectin pathway. So what does it mean? There is alternative or mannose binding lectin pathway activation. So C4 will be normal in this patients, okay? Even C3, in fact, complements are going to be normal only because it's going to be local stimulation. So there is no hypocomplementemia that is seen in IgA nephropathy. This is also very, very important. Though it is an immune complex disease which activates complements, you are not going to find any complement deficiency in these patients. Now, coming to the clinical features, 90% of these patients are sporadic. It's not like there is any familial inheritance seen. And in Asian population, male and female have equal preponderance. Now, if you see the age in which it presents, one is IgA vasculitis. I'll be coming to it later. It's mostly seen in the young children, maximum by 20 years of age. After that, the incidence reduces. Next is macroscopic hematuria. So macroscopic hematuria, you see, it might start somewhere less than 10 years of age and it ends by around 40 years of age. Asymptomatic urinary abnormality is what is most commonly seen. That is, it starts somewhere between 10 to 20 years of age and it goes till 50 to 60 years of age. So that is seen in the wide variety of spectrum. Then comes nephrotic syndrome. That's also not very common. It is seen between 10 to 50 years. Okay. And chronic renal impairment generally starts after 20 years because disease starts by 10 years. It takes around 10 years to reach to CKD. Now coming to the clinical features. The important clinical features are, they can either present as macroscopic hematuria or they can present as asymptomatic urinary abnormality. So macroscopic hematuria is seen in 40 to 50% of patients. Approximately half of the patient present with macroscopic hematuria. And this mostly starts in second decade, like we saw here. Almost, it can start less than 10 years. In the second decade, it has maximum incidence, okay? And it is episodic. It's not like it's continuous. So whenever infection occurs, throat pain occurs, or some GI symptoms occur, this is going to happen, okay? And like any glomerular hematuria, it is brown and it has no clots. Loin pain can happen. Sometimes if hematuria is massive, there can be loin pain. It is synpharyngitic, which we already discussed. And this resolves by itself. It just does not require any treatment. It's going to resolve by itself. And if it is massive, like think the glomerular hematuria is massive, all this hematuria is going to come and it's going to occlude the tubules, okay? So this is going to cause AKI. So it's seen in 40 to 50% of the patients and it is mostly synpharyngitic. It's brown color, it does not have clots and it's going to remit by itself. However, it can cause AKI and it's mostly seen in second decade and it comes in episodes. Okay, it's not persistent. So these are the features of macroscopic hematuria. Now, asymptomatic microhematuria and proteinuria, this can be seen in the rest 30 to 40% of patients. Okay, so this will be detected only by routine urine testing. So many of us who have never got a urine routine, if we get tested, we might have this microscopic hematuria or proteinuria. However, if there's no hypertension, if there is no deranged renal function, only observation is the treatment. Okay, lifestyle modification and observation. Now, some patients can also present as nephrotic syndrome. It is seen in less than 5% of patients. It's not very common. However, in India, so all these, you know that we mostly read Fihali's textbook. So all these data is from abroad. But Indian data recently done shows that in Indian population, approximately 20 to 30% are presenting with nephrotic syndrome. But for your exams, for all practical purposes, nephrotic syndrome is less than 5%, okay? And serum complement levels are going to be normal. Now, acute kidney injury also is less than 5%. So two things that have incidence less than 5% is one is nephrotic syndrome. Second one is acute kidney injury. So this can be because of two important reasons. One is the disease can have crescents. So if you go to the chapter of anti-GBM, I have discussed about rapidly progressing glomerulonephritis. In that, one of the reasons for RPGN, which is nothing but the clinical counterpart of crescentic glomerulonephritis, I have described it as IgA vasculitis. Okay. And the one is that, so crescentic transformation can occur. Second one is, like already I described, there is massive glomerular hematuria, which is going to come and occlude the tubules, and then it is going to cause acute kidney injury. Okay. Now, there can be some incident renal insults like patient having diarrhea and taking some AC inhibitor, or patient having some other pre-renal cause of AKI, some obstructive uropathy, anything like in general population. So these causes also can happen in IgA nephropathy. Now, not just IgA nephropathy, there are other diseases that can be associated with IgA deposition in the kidney. Okay, so these will be called as secondary IgA nephropathies. Why it's important is, in these conditions, whatever kidney involvement is seen will resolve only when we treat the secondary disease. So it can happen in rheumatic and autoimmune diseases like ankylosing spondylitis, rheumatoid arthritis. Okay. It can happen in gastrointestinal conditions like, for example, patient has Crohn's disease or ulcerative colitis. It can happen in hepatic. This is very important. Like it can happen in patients with cirrhosis. Where we see this clinically is, we generally get patients for fitness for liver transplant. Okay. So when we assess these patients, we ask for urine routine. We notice that these patients will have some proteinuria. And we cannot give fitness because if the patient has any glomerular disease or any chronic kidney disease, doing combined transplantation will help this patient. Otherwise, after doing liver transplant, patient will end up in kidney transplant. So to avoid this, what we do is we do renal biopsy and we find that majority of these patients have IgA deposits in the kidney. Okay. Majority of these patients have IgA deposits in the kidney. Okay. Now, next is lung involvement. Any condition that is causing lung involvement like sarcoid can lead to IgA deposits in the kidney. Skin involvement is dermatitis herpetiformis. Again, infection like HIV or HBV can lead to IgA deposition in the kidney. Now coming to the pathology. In pathology, in immunofluorescence, we are going to see diffuse mesangial deposition of IgA. But if this IgA is deposited in mesangium, it is IgA nephropathy. If IgA is deposited in the capillary loops, then it becomes vasculitis. Okay. Now, along with IgA, like I said, alternative pathway or the MBL pathway, the mannose binding lectin pathway gets activated, so C3 gets co-deposited. IgG and IgM can also be present. So there's nothing to get startled if we find these two in the immunofluorescence report in 40% of cases. So C5b to C9 is involved, hence C4 is going to be negative. Okay. This we have already discussed. Now coming to the light microscopy, if you focus on the mesangium. So these are the capillaries that you can see. This is the mesangium. Okay. So there is going to be mesangial hypercellularity. Okay. Which can be diffuse or which can be segmental. Sometimes if there is this crescentic transformation like IgA vasculitis, there is going to be focal segmental necrotizing GN. So this is not like a very scary thing. See, what happens is capillaries get involved, right, in vasculitis. So these capillaries are going to die. So that part of the glomerulus is going to get necrosed. So it's going to be focal and segmental. That is, only few glomeruli can be involved and only segment of that glomeruli. For example, if this capillary is affected, this segment gets involved. Okay. And with crescent, extracapillary proliferation is nothing but crescent. Sometimes there can be endocapillary hypercellularity also. And in advanced cases, this focal and segmental glomerulosclerosis. Okay. So in a plain IgA nephropathy, you can find mesangial proliferation. Sometimes you can find endocapillary proliferation. Now, this scoring is also called as Oxford classification. Okay, so this is a pathological system which helps in telling the prognosis of the patient. Okay, so MEST is whenever you see a biopsy report of IgA nephropathy, you will be seeing this MEST scoring. Okay, M is mesangial hypercellularity, E is endocapillary hypercellularity, S is segmental sclerosis, T is tubular atrophy. See, it's pretty simple. What are the things that I told you we'll see in light microscopy? One is mesangial hypercellularity. Second is endocapillary hypercellularity. So these two are the only things that can happen because IgA is sitting in the mesangium and maximum associated near endocapillary region can get involved. When this happens, what will happen? There's going to be, that area is going to get sclerosed. So segmental sclerosis. Once the glomerulus gets sclerosed, the surrounding tubular area undergoes atrophy and there's going to be interstitial fibrosis. Now there was another addition to this, that is C, like you can guess, C is crescents. Okay, so it came to be known as MEST C score. So it is important in prognostication of the patient. And when you see in electron microscopy, you're going to see electron dense deposits, that is nothing but antibodies in the mesangium. And there can be focal thinning of GBM. Now again, this you are going to see in thin basement membrane nephropathy, where there's going to be focal thinning and there can be some hematuria. Now, differential diagnosis. The most important differential diagnosis is staph associated post-infectious glomerulonephritis. Okay. So in this, what happens is it's mostly seen in elderly immunosuppressed patients who develop some staphylococcal infections. Patient is going to present with AKI and hypercomplementemia because this is infection. Complement pathway gets activated. C3 is going to be reduced. And there is going to be endocapillary hypercellularity also, which is much more than IgA nephropathy. And unlike in IgA nephropathy, where IgA is going to be the dominant one, that is IgA in IgA nephropathy is going to be 3+ and C3 can be 2+. So this indicates the intensity of the staining. So in IgAN, IgA is going to be dominant, whereas in CLGN, that is associated with staph, C3 is going to be 3+ and IgA is going to be 2+. Okay, so the intensity of staining is going to change. Now, here are some conditions which shows mesangial IgA deposition. That is IgA nephropathy and vasculitis. We already know that. Lupus nephritis, alcoholic liver disease, like I mentioned. Some IgA monoclonal gammopathy, infections like schistosoma, and IgA dominant staphylococcus glomerulonephritis. That is already described. Okay. So it's not important to remember all these things. Alcoholic liver cirrhosis is very important, that you have to remember. And this IgA dominant staphylococcus, because this is going to be the most important differential. Now, if there is one slide that is most important in this chapter, it is this, which are the prognostic indicators. So first, remember the thing, see, because poor prognosis are many things, okay. Remember the good prognosis and no impact. Generally the questions are going to be like, all of the following causes poor prognosis except, because they can fit that except in this option, right? So, good prognosis is recurrent macroscopic hematuria. So, this has been asked multiple times in AIIMS and PGI entrance. What happens? Why recurrent microscopic hematuria should be a good prognosis, you might be wondering. It's just because of simple reason. When there is recurrent macroscopic hematuria, it's going to happen early in second decade and patient is going to go to the doctor early. Imagine if something is asymptomatic, no one is going to go and they present in advanced stage. In this condition, they are going to present early, because of which detection is going to be early, treatment is going to be early, right? Now, so that is why recurrent macroscopic hematuria becomes good prognosis. The things that have no impact on the prognosis are gender, serum IgA level, and intensity of IgA deposits. Okay, so whether male or female gender, whatever is the level of serum IgA, and how much is deposited in kidney, whether it's 3+ or 2+ or 4+ or whatever it is, it has no significance. So once you remember these things, the other things is okay, because see, this is not a theory paper, it is an MCQ question. So mostly the questions will be of exception of which this will be the options. For example, a question will be like, they will give you a clinical scenario of IgA nephropathy. Then they will ask all of the following are poor prognostic factors in this patient except, out of which this recurrent macroscopic hematuria can be an option. Okay. So poor prognostic factors are classified into two. One is clinical, one is histopathologic. So hypertension, of course, renal impairment, proteinuria if it's severe, smoking, hyperuricemia, obesity, long duration of preceding symptoms, and increasing age. Okay, so these are general poor prognostic factors in any kidney disease. And coming to histopathologic, mesangial hypercellularity, endocapillary proliferation, tubular atrophy, sclerosis, interstitial fibrosis. So this is nothing but MEST. Again, capillary loop IgA deposits, which is indicating vasculitis, and crescents. But crescents is controversial. Okay, it's not very much proven that presence of crescents is harmful. So this is very important prognostic indicators. Now coming to the natural history of the disease. Generally, after 20 years of symptoms starting, 25% of patients progress to ESRD and 20% develop progressive renal impairment. So approximately 45 to 50% of the patients are going to have CKD, out of which 25% is going to land up in ESRD. So this is actually a very huge number. Now what happens if these patients reach ESRD and we transplant? Is this IgA nephropathy going to come back? Generally, it's going to happen after 10 years. So that's a very safe period. But this doesn't mean that there are not going to be IgA deposits in the kidney, because you know the problem is with the galactose deficient IgA, which gets deposited, right? So this mesangial IgA depositions are seen in 60% within few days or weeks. But what are we doing? We are giving immunosuppression in transplant patients, right? We are giving them CNI, we are giving them steroid. So this will take care of the disease. So in short term, whatever that's whatever I told, this within weeks or months or first few years, whatever IgA is found, it is benign. We need not panic about it. And somehow it was noticed that the cadaveric kidney does better than the live related kidney. Okay. So why is this? It was noticed because probably in cadaveric kidney, or when you're giving a HLA mismatched kidney, we are going to immunosuppress the patient heavily, right? Because in a live related fully matched donor, our immunosuppression is going to be light. So this heavy immunosuppression is what is helping in IgA nephropathy. Okay. Now this is a treatment outline. So this is just the outline. We will be discussing the KDIGO guidelines again in detail. So you classify them into low risk, intermediate risk, and high risk. What is high risk? When there is acute or rapid loss of GFR. Okay. So it can be because of nephrotic syndrome or crescentic IgA with RPGN course. So in this you have to add immunosuppression. If it's due to macrohematuria, we have to give supportive therapy. Again, the low risk patients, that is only microhematuria with or without proteinuria, which is less than 500. GFR is normal and no hypertension, it's only supportive therapy. The intermediate risk, that is proteinuria has crossed 500 milligram. Patient has low GFR, patient has hypertension. So you give them supportive treatment for 3 to 6 months. If this supportive treatment is not going to work, then you categorize these patients into 3 categories. One is GFR less than 30, no point in giving immunosuppression, continue supportive treatment. If GFR is 30 to 50, then you continue supportive treatment and can consider immunosuppression. If GFR is more than 50, see the proteinuria. If proteinuria is less than 1 gram and patient is stable, continue supportive therapy. If proteinuria is more than 1 gram, then consider immunosuppression. So it is proteinuria more than 1 gram per day and GFR more than 50 ml per minute. So these two becomes the indication to start immunosuppression in the patients of IgA nephropathy. Okay. Now there are other supportive therapies like antihypertensives, which is most important. ACE or ARB is considered as first line because it prevents proteinuria, and also fish oil is considered. See, fish oil generally is taken in large doses It can be given because there is no side effect of giving it. It contains omega-3 fatty acids. But the adverse effects like flatulence and cost of affording this is the main hindrance in giving this therapy. Now, there are two trials which have been asked in exams with respect to IgA nephropathy. Both are about steroids. The first one is STOP IgA trial. So this was done in two parts. The first one was quite long ago, that there was only 3 years follow-up after giving steroid. And the recent one was after 10 years follow-up of these patients, they have reported again. Okay. So in this, it is seen that there is no benefit. Okay. IgAN patients did not benefit from additional immunosuppression on top of supportive care measures. So this STOP IgA trial shows no benefit of immunosuppression. Then other important trial is testing trial. This also checked the effect of oral methylprednisolone in seeing IgA nephropathy. Though oral methylprednisolone reduced the effect of declining GFR, but there were high adverse effects. Okay, actually this trial was stopped early because it was high dose therapy and so many adverse effects are seen. So basically in IgA nephropathy, immunosuppression is just plus or minus. There are no heavy indications to give immunosuppression except for those two things that I told you. Okay. Now, coming to crescentic IgA, how will we manage this? Like any other RPGN, we will give pulse steroid, cyclophosphamide, and renal survival is very, very poor. It is 30% at 5 years. Now, other treatments are, because we know once the infection comes to the mucosa, this whole process is triggered, and patient with tonsillitis will have recurrent infection. So, tonsillectomy is one important thing that can be done to reduce IgA production. Second thing is there can be continuation of steroid post-transplant. Once the post-transplant, how to reduce recurrences, we continue steroids. Like of course I said, this will reduce the recurrence. Now coming to IgA vasculitis or Henox-Collin purpura. This is mostly disease of children. It is less seen in adults. Okay. So it is a small vessel vasculitis. So where does it affect? It affects the skin. It affects the gut. It affects the kidney and it affects joints. Okay. So in a human being, it affects the skin, then it affects the gut. Next to the gut, there are kidneys, it affects that, and the joints. Okay, so these four are the sites which this affects. Now, this is more commonly seen in children. Okay, generally, it just causes transient urinary abnormalities in acute phase. The clinical feature is it is mostly seen in the first decade of life. Now, in skin, what is seen? It is palpable purpura, which is seen in the extensor surface, like in the gluteal region or in the extensor surfaces of the leg. So that is in the skin where it is causing rashes. Next, in the joints, like we mentioned, it causes polyarthralgia. In the gut, it causes abdominal pain because of gut vasculitis. So in children, this condition is generally self-limiting and biopsy is not required. So in children, it is self-limiting and biopsy is generally not required. In adults, mostly they will have purpura, arthralgia and pain. Purpura is most common. In adults, it generally complicates. It's not transient. It's not self-limiting. So biopsy will be required. So renal involvement, most common, especially in children, is asymptomatic urinary abnormality. Nephrotic syndrome can be seen in 20 to 30% of patients. Some patient can have crescents also. Okay. Pathology is going to be same as IgA nephropathy, that is mesangial proliferation, endocapillary proliferation, IgA deposits in the capillary loops and in the mesangium. Now, generally, adults have worse prognosis than children, with 40% of them progressing to ESRD by 15 years. So, this is more than IgA nephropathy, which is just 25% progressing to ESRD in 15 years. Even in transplantation, this can recover. And delaying in transplantation, once ESRD is reached because of IgA vasculitis, is not going to delay the risk. This is unlike in ANCA vasculitis, where we suggest 1 year gap to maintain after ESRD is reached, and in anti-GBM, where we maintain 6 months. So here gap is not required because it makes no difference in the outcome with respect to recurrence. Now, treatment is, if there is crescents, then again cyclophosphamide, steroid, plasmapheresis. If it's normal renal function, there is no evidence of immunosuppression. But if patient is going into CKD, tight BP control is the only thing that is going to help. Now coming to the KDIGO guidelines. Renal biopsy is indicated in all patients suspected to have IgA nephropathy. MEST-C scoring should be put in the pathology once the biopsy is done. There are no serum or urinary biomarkers to detect IgA nephropathy. So serum IgA levels does not help us in identifying IgA nephropathy. And always we have to assess for secondary causes. Might be rheumatologic, might be gastrointestinal, might be hepatic, infections, malignancies, like I already discussed. So, an international prediction tool which predicts the risk of ESRD at 5 years and CKD ESRD at 5 years and 10 years came up. Okay. So, this is called as IgN prediction tool. So, this is very important. This has been asked as question recently. So, you have to just know what are the components of it. So, think patient comes to you. Okay. So, in the history, you are going to see race and you are going to see age. Okay. Then you are going to ask for medication history or treatment history. So, you are going to see if patient is going to take AC inhibitor at the time of biopsy, or is the patient already on, immunosuppression at the time of biopsy. Okay. So, this is 1, 2, 3, 4. Then on examination, you are going to see the systolic blood pressure, the diastolic blood pressure. Okay. And in pathology, you are going to see the MEST score. So, these are the 1, 2, 3, 4, 5, 6, 7 parameters. Now, this MEST will be divided into 4 separate parameters, right? So, here you can see there is systolic blood pressure, diastolic blood pressure, age at biopsy, race, use of AC inhibitor or ARB, MES score, M, E, S and T, and immunosuppression use at or prior to the biopsy. So, based on this, the scoring is done. Treatment is, it can be supportive therapy where there is BP control, salt restriction, and so this is the initial assessment like I already mentioned. Once patient has IgA nephropathy, see whether it is IgA vasculitis or secondary causes like HIV, hepatitis, inflammatory bowel disease, autoimmune disease, liver cirrhosis, okay? Or there is IgA dominant infection related glomerulonephritis. If that is not there, you label them as idiopathic IgA. You see the MEST score. Then you classify the patient based on IgN prediction tool and you find out their chance to progression to ESRD. Enroll the patient in disease registry if you are planning to start the patient on an immunosuppression. Otherwise, it is supportive care, BP management, ACARB, lifestyle modification, and address the cardiovascular risk. So, like I was telling, if proteinuria is more than 500, start the patient on RAS blockers. Which are the patient at risk of progression? That is, if proteinuria is more than 750 to 1 gram, despite maximum supportive therapy, even after achieving BP target, like we discussed. So, these are the patients which can be considered immunosuppression. And when GFR is less than 50, especially less than 30, even if this parameter is there, generally we don't consider immunosuppression. Okay. There is insufficient evidence to use MEST-C score or crescents to guide regarding immunosuppression. Okay. So, generally we give steroid for 6 months. So, there is no evidence to give steroid based on MEST score or presence of crescents. So, this is a management chart. So, proteinuria more than 1 gram per day despite 3 months of optimized supportive care, that is BP management, ACARB, lifestyle and cardiovascular risk. Then consider enrolling them in the trial if eGFR is more than 30 and if there is no risk like advanced age or metabolic syndrome, obesity or latent infection. Basically, there is no contraindication to give steroid, then you can give steroid. But if eGFR is less than 30, go for supportive care. This is not applicable to variant forms of IgA like IgA with minimal change disease, IgA with AKI or RPGN. Then this is not applicable to IgA vasculitis or IgA nephropathy which is secondary. Okay. Specific population where specific treatments are helpful is Japanese consider tonsillectomy, where universally all these patients undergo tonsillectomy, and in China they consider giving MMF as a steroid sparing agent. Okay. So in Japan, it's tonsillectomy. In China, it is MMF. So this is a various steroid protocol. You don't have to worry about it. We generally follow the Manu protocol or the testing protocol. Generally, the duration is 6 to 8 months. Okay. So in testing protocol, we saw that they are giving methylprednisolone and it caused more serious side effects. So more so, we follow the Manu protocol where we start 1 mg per kg steroid. We give it for 2 months and then we start tapering it down and we end it by 6 months. Contraindications for steroid. eGFR less than 30 that we already discussed. Patient having diabetes, obesity, any latent infection like TB, viral hepatitis, any secondary disease like cirrhosis, there is no point giving. There is active peptic ulcer, psychiatric illness or osteoporosis which can get worse by steroid. Now, these are all the agents that are useless. Okay. So just go through this list once because if it is asked as an exception question, for example, all these are useful in IgA nephropathy except first might be fish oil, second might be tonsillectomy, third might be steroid, fourth option might be rituximab or CNIO, cyclophosphamide, azathioprine. See, all these are used in other things. So the fish oil also in the recent recommendation, it's considered as not recommended. Though in the textbooks, it says that it's recommended. In the recent guidelines, it is telling that it's not recommended. Okay. So, though rituximab, CNI, cyclophosphamide, azathioprine are considered good enough in other nephropathies or other glomerulonephritis, it is not considered good in this. Next is this drug called mycophenolate mofetil. So, there are no data in other population. Only in Chinese patients there is data. So it is used as a glucocorticoid sparing agent in China. So in non-Chinese patients, there is no data. But however, in India, we are using this for few patients. Next is hydroxychloroquine. Similarly, only in Chinese patient, there is data and there is no data in other patients. But however, all these things will not replace supportive care like after lifestyle modification and giving maximum hypertension treatment with ACE/ARB. And controlling the blood pressures, we should go behind all these things. Other thing is tonsillectomy, which should not be routinely done in Caucasians. However, in Japan, it is done routinely. And if they are having nephrotic syndrome, if it is presenting like MCD, treat like MCD. If only IgA nephropathy is found in the biopsy with nephrotic syndrome, treat as IgA nephropathy. If it is FSGS, then it is generally secondary. So again, supportive treatment is the treatment of choice. Now, once AKI happens, if it is crescentic GN, we consider treatment of crescentic GN. Like I have already discussed, it is going to be pulse steroids with cyclophosphamide and with plasmapheresis. However, if it's macrohematuria, it is supportive care. RPGN is when there is more than 50% decline in GFR over less than 3 months. Okay. In biopsy, generally we see endocapillary hypercellularity with crescents in these patients. Treatment is cyclophosphamide and glucocorticoids like ANCA-associated vasculitis, and there is no role for rituximab. Okay. So one glomerular disease where rituximab is not going to play any role is in IgA nephropathy. In children, generally if proteinuria is more than 200 mg per day, we give RAS inhibitors. Glucocorticoids are more frequently used in children when compared to adults, okay, when proteinuria is more than 1 gram per day. Now, vasculitis, generally I told it is transient and it is self-limiting. So, there is no indication to start steroids to prevent renal presentation in extrarenal disease. So, just because patient has some rash or arthralgia and you start steroid doesn't mean that the renal disease is going to not come. And don't use MES score or IgA prediction tool in IgA vasculitis. Presence of crescents itself is not an indication for immunosuppression. So just because crescents are there, if the renal functions are normal, then there is no need to give immunosuppression. Okay, if immunosuppression is planned, steroid is the drug of choice. And if it presents as RPGN, treat it as ANCA-associated vasculitis. Okay. Now, majority of children develop nephritis within 3 months of presentation of systemic disease. So, we have to keep children under watch for these 3 months. And if there is persistent proteinuria more than 3 months, ACE inhibitors is the drug of choice. Kidney biopsy will be done only in these conditions: if there is nephrotic range proteinuria, or there is impaired GFR, or if there is persistent moderate proteinuria, not just nephrotic range, but proteinuria that is persistent, that is not resolving over 3 months. In adults, we do biopsy for everyone, okay, because they are expected to complicate. In adults, we do biopsy for everyone because they are expected to complicate. So oral prednisolone or pulse methylprednisolone is what is indicated in this condition. Now, coming to the last part of the chapter, which is quick revision. Now, the other name for IgA nephropathy is Buerger's disease. This is also called as synpharyngitic hematuria when compared to PSDN, which is postpharyngitic. That is, along with the infection, the hematuria occurs. AK and IgAN can happen because of crescents. It can happen because of macrohematuria, and it can happen because of incidental reasons. So if it is crescent, you treat it as RPGN. If it is macrohematuria, it is supportive treatment. MEST score. MEST score is nothing but mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, and tubular atrophy and interstitial fibrosis. Now the addition is C, that is crescents. Okay. The post-infectious glomerulonephritis versus IgAN. Here there will be IgA dominant post-infectious glomerulonephritis. How to differentiate is, this is because of generally staph infection. It is seen in the elderly who are presenting with AKI and reduced complement level, and C3 deposits are going to be more than IgA. C3 deposits are going to be more than IgA. Now, prognostic indicators, like we discussed already. See what is good prognosis first. Learn up that. That is recurrent macroscopic hematuria. Then the factors which have no effect on the prognosis is serum IgA levels, or intensity of IgA deposits, or gender. Rest all are the poor prognostic factors, which can be clinical or pathological. Clinical, again, hypertension, renal impairment, hyperuricemia, obesity, smoking, and severe proteinuria, increased age. Similarly, histopathologic will be nothing but our MES scoring: mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, tubular atrophy, interstitial fibrosis. You have to know that crescents is controversial. Okay, capillary loop IgA deposits is also will have poor prognosis. Now, IgN prediction tool, we know that it helps in predicting the CKD or ESRD at 5 years and 10 years. However, this is as of now not used for treatment decision. So there are important parameters that are used in this. So first is clinical. What is the race of the patient and what is the age of the patient? Okay. Then once this happens, you will take the treatment history. That is, what is the medication patient is on, whether the patient was taking ACE inhibitors or ARB when they already came to you, or whether they were already on immunosuppression when they already came to you, right? So these are the parameters that you are going to assess. Next, you are going to come to BP. That is, you are going to see the systolic blood pressure and you are going to see the diastolic blood pressure. Next is the pathology. In the pathology, you are going to assess the MEST score. So these are all the parameters that are going to be taken to assess IgA prediction tool. Okay friends, I hope I have improved your understanding of IgA nephropathy. Till I see you next time. Bye.